Hello, and welcome to GAPNA Chat, an official podcast of the Gerontological Advanced Practice Nurses Association. GAPNA Chat provides interviews and discussions with GAPNA leaders and members of the gerontological healthcare community, and will focus on advocacy, policy, education, professional development, research, and clinical care for older adults. In this episode, Dr. Cassandra Vonnes, a gerontological nurse practitioner and member of the GAPNA Communication Team, talks with Dr. Carolyn Clevenger. Dr. Clevenger is a nationally recognized leader and researcher in gerontological nursing and education, and a past president of the Gerontological Advanced Practice Nurses Association. Dr. Clevenger discusses Alzheimer's disease and dementia and provides an overview of her research in this area. She details how clinical characterizations of Alzheimer's disease have evolved over time, the role of nurse practitioners who provide care for older adults with Alzheimer's, signs and symptoms of Alzheimer's in patients, and exciting new advances in the treatment of Alzheimer's disease. We are pleased to present Dr. Vonnes' interview with Dr. Clevenger.
Welcome to our Series 2 GAPNA Chat, and we have Dr. Carolyn Clevenger here with us today. She is a gerontological advanced practice nurse and associate dean for clinical and community partnerships at the Nell Hodgson Woodruff School of Nursing at Emory University in Atlanta, Georgia. She's also the clinical director and a practicing nurse practitioner at the Emory Integrated Memory Care Clinic. And we are so excited to have Dr. Clevenger back again with us on our GAPNA Chat. Let's just start talking a little bit about Alzheimer's disease and your area of research and clinical interest. What is the most exciting Alzheimer's research advance that you have seen in the last 10 years?
Hi, Sandy. It's good to be with you again. This is actually my very favorite topic to discuss. I know we talked about leadership on a previous podcast. That is going to be second favorite, but this is like the thing I like spending the most time talking about. So just to give a little quick snippet about integrated memory care, because it's so unique in our practice model. It is a primary care practice, a nurse-led primary care practice, exclusively for people with a dementia diagnosis. And their dementia can be any type. Alzheimer's, of course, is about half of our patients. We also have folks with Lewy body disease, frontotemporal degeneration, vascular dementia, of course, and a smattering of others. I've really been focusing my work just on people living with a dementia diagnosis and their families, since about 15 years, I guess, at this point. And integrated memory care has been incubated and lives today within Emory Healthcare, which is an academic medical center. And so a lot of times when families are seeking our practice, they always want to ask this exact question: what is happening in the research space around Alzheimer's disease? And I generally say that the research right now and over the last decade, it lives basically in sort of three large categories. So one, I think, which is most often on patients' and families' minds, is about the pathology and ways that we can both identify that pathological process and intervene to modify or change the course of the disease. That is what I think of as the cure-oriented research pathway. There is also a care-oriented pathway, which is that for the almost 7 million people living with a form of dementia, most of them Alzheimer's disease, we don't necessarily know today what is the best way to provide care for those individuals. And so models like integrated memory care are new practice models that we believe, based on best available evidence, expert consensus, would lead to better outcomes and a better experience overall, both for patients and their families. So there's new models of care in lots of settings. Mine happens to be in a clinic-based primary care, but there are other settings where that research is ongoing. What's the best way to deliver care? And then the third area that I see very frequently is interventions to best support and bolster and train what is today our most effective intervention, which are caregivers, sometimes called care partners. Many of those research projects are targeted toward educating caregivers, providing psychosocial support as well, logistical support too. So those are sort of my three buckets. I would say both identifying the diagnostics and the interventions, the models of care, and then caregiver research. And I think each of those areas has some really exciting and positive work and discoveries, thanks, of course, in large part to a lot of funding from both NIH, National Institutes of Health, so federal funding, other federal agencies, and foundations at this point. So a lot of researchers have been targeting their work in these areas so that we're learning so much more and so much more quickly.
That's so exciting that there is a holistic approach, not just a pharmacologic. Now, I know
Absolutely.
that the clinical characterizations of Alzheimer's disease have evolved to give us new biological definitions. How have those evolved over time? We've gone from requiring a brain biopsy for diagnosis to where we are today.
So today we would say Alzheimer's disease is a clinico-pathological syndrome. And I should probably say Alzheimer's dementia is a clinical pathological syndrome. It is both of these ideas. And some significant things have changed around our ability to measure through something other than a brain biopsy, because as much as people might want to know, we have to make light sometimes of our work at clinic. And so, we're not going to go in there and do a quick brain biopsy, and we still can't do brain transplants. So something a little bit more accessible to people while they're living. Those things have evolved to the point that we can use them. Some of them much more evolved than I think most people realize. We'll talk about that in a second. So when I was in training in the Gerontology Nurse Practitioner program, we did talk about brain biopsies, of course, for actual definitive diagnosis that this dementia syndrome was caused by Alzheimer's disease. But by and large, we would have said, we can be fairly accurate. And I think it was upwards of like 80% accuracy by looking at what are the symptoms that are appearing in which order. And the cluster of symptoms, of course, then comprises what we think of as dementia syndrome. So, of course, that's our DSM-5 definition, which is impairment in 2 or more of our cognitive domains, of which there are 5. And in the case of Alzheimer's disease, the most typical pathway that we would see would have been beginning with memory first. So amnestic appearance initially, lack of awareness or anosognosia would also be sort of a part of that because memory is so affected. And then we would have sort of progressed from there in a fairly predictable disease course. Of course, there are atypical disease courses too. So we start to see those, and then you kind of get a head scratcher, like, is it another cause? Are there a couple of concurrent diseases going on in the brain? Does this person just happen to present differently? We could have gotten a little more fine-tuned with some structural imaging, ideally an MRI, but for people who could not complete an MRI, maybe a CT scan, specifically to look for regions of the brain that show change in the hippocampal area. So we would have said, what is the hippocampal volume as a percentile compared to other age and gender-based norms? And we could have said pretty predictably, this is dementia due to Alzheimer's disease. And we would have said probable or possible due to Alzheimer's disease. In Alzheimer's disease and in the other sort of major causes, we do know that there is this biological component of a protein often that deposits itself in the brain. In the case of Alzheimer's disease, it hasn't been that long ago that we've changed our criteria for diagnosis to something called the ATN criteria. A stands for amyloid, T stands for tau, and the N is for neurodegeneration. So evidence of neurodegenerative process going on. And now in the case of both amyloid and tau, we have been able to actually collect and measure that through a couple of different means. First, through cerebrospinal fluid, which many practices, including my colleagues at Emory, will use fairly frequently. It is covered by insurance. You have lots of challenges of people who are uncomfortable with the idea of a lumbar puncture. I mean, when I present to people, and I'm seeing post-diagnosis patients, of course, but maybe they haven't been characterized very specifically. Some people don't want to be, right? I say, okay, if you're interested, this is what it would require. You say lumbar puncture and you kind of get a cringe. There are also stains and special scans that we can do with an amyloid tracer agent called Amyvid, which is FDA approved, but not Medicare approved for payment. And so we have had the ability for a few years now to measure amyloid burden in the brain. but it's not covered by insurance. And so that then, of course, has lots of equity challenges, and it's not offered everywhere. So you have where you happen to live is a challenge, and your ability to pay out of pocket outside of a research study. If you're a participant in a research study, like a neuroimaging study, it's covered. And that is honestly how many of us in the cognitive neurology clinical space have gotten patients those kinds of tests. Now we actually have an FDA approved blood-based test for amyloid. I mean, I have patients who are asking about that. That's, I believe, called proclivity. So I don't know that that is covered by insurance. I don't believe that it is. It is often a private pay, but it's FDA approved. And we have similar measures for tau, both through the cerebrospinal fluid and through our scans. So we can actually measure the biomarkers of Alzheimer's disease. Unfortunately, we don't have a parallel way to test the pathological process in Lewy body or frontotemporal disease. So those are still, I think, in progress. But talking about Alzheimer's disease today, we can now know with some certainty that this person has Alzheimer's disease. I'll just add one other thing. I could go on about this, but it is foundational to what we're going to talk about. And that is when you think about the ATN criteria, it's very obvious when someone's test results come back and they're positive for amyloid at a volume higher than you would have expected. They're positive for tau, and they have neurodegeneration, right? Check, 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 all 3 boxes. Some people only check 2 of those boxes or 1 of those boxes. And so now we really are starting to get into a space where it's a question, because people can have high levels of amyloid for reasons other than Alzheimer's disease. There's some age-related rise in that protein anyway. Anyway, things start to get a little bit sticky in terms of whether we can say, yes, this person definitely has Alzheimer's disease, or is this a whole group we might call Alzheimer's disease disorders, meaning that someone has more than one type of Alzheimer's disease, which is just a whole new way of thinking about it entirely.
That becomes very important when you're looking at diagnosis. Now, the National Institute on Aging and the Alzheimer's Association have identified, like you said, close to 7 million people living with actual cognitive impairment,
right,
and a diagnosis of Alzheimer's disease. But then they estimate that there's another almost 47 million that can have that preclinical disease. And if I'm a nurse practitioner in primary care practice, what would these kinds of estimates mean for me when it comes to the biometrics and the scans for my patient population that may be in that preclinical category?
This is a huge question. I mean, this is a big point of burden. And I think the more that we start talking about treatments being available, the more we're going to have people asking for this kind of testing. And so I should add that ATN framework, which is that framework, is in chronological order, we believe, meaning that amyloid rises first up to 2 decades before the first symptom appears. So certainly there are people who we would say diagnostically, based on their biomarkers, have Alzheimer's disease, and they do not have cognitive impairment or certainly not dementia syndrome. And so this is like a whole new group of people. And what do we do with these people? Well, it may be that those are the people who have some of the highest opportunity for intervention. So the idea that this is kind of our question, and it has been for a while since that framework was, I think there's a framework published by Jack and colleagues where it sort of schematically draws out this idea that amyloid rises first, it actually plateaus and pretty much stays at the same level. And then tau rises next. And then neurodegeneration happens. But as people are then developing their symptoms, we're starting to see some amnesia, we're starting to see word finding difficulties, apraxia, that the amyloid actually it doesn't continue to increase. And so the idea then in our space of Alzheimer's disease is like not treating someone until they have symptoms is like where cardiology was decades ago, right? It would be like not treating someone's high cholesterol until they had their first heart attack. So, the damage is done. We've already kicked off all of these other processes that have started, and now we're losing brain cells gradually. So it's one of the challenges, I think, in the clinical trials where we're testing these drugs. We'll talk about the newest drugs that are finally approved, but that follows something like 17 failed agents that are also amyloid targeted. And so why is that? Is it because we are treating the cholesterol after the first heart attack? Is it that we're waiting for people to have symptoms? So on the one hand, and when we talk about the logistics and cost of the treatments that are coming out, 47 million people who are appropriate for treatment is like, how in the world in our admittedly broken healthcare, I'm not going to say the word system, the way we organize health, the business of healthcare, that is an overwhelming number. At the same time, what an amazing clinical opportunity potentially to intervene with people who have amyloid early and have maybe not triggered those other cascading processes. Is that a way to actually curb what is coming or maybe delay what is coming with the rest of the brain degeneration? Because we've known for a long time, if we can just delay onset of symptoms, frankly, because this is an age-related illness, other things may happen that lead to mortality other than this slow, gradual decline of Alzheimer's disease, which for many people is exactly what they would like to avoid when you think about what would a good last year of life look like or a good death. So we would have fewer deaths from Alzheimer's disease and from that kind of slow degeneration and that last year of frailty. So on that hand, the other thing I would just say about the preclinical people who have no symptoms, again, we're going to assume that they're fairly early in their amyloid rise. Amyloid has its own life course. So all amyloid is not equal. When you begin to build up this protein, and it's a specific 42 and 43 chain amyloid, beta amyloid protein, it begins as a fairly flexible piece of protein. And as it begins to build and catch other pieces, it does harden and then embed itself. And so that's, again, one of those challenges. We don't, as far as I know, readily have a way to say this is soft amyloid or this is hardened amyloid. And so I think when you treat amyloid and the drug is so effective and it removes it, removing something that is fixed and hardened in your brain is very different than removing something that is still quite soft and manageable and we can just clear. And I have a whole analogy for the difference between the two, which I think about, if you think about the process of clotting when you scrape your knee, for example, right? So you scrape your knee and it's bleeding and there are some like clotting factors coming to the place. But if you wash it off, we know we can wash it off and it's all going to come off and that's not going to be an issue. But if you wait until those have all hardened and there's a nice firm scab there and that gets pulled off, we know that causes the fresh bleeding and swelling and inflammation again, right? So it matters to find these people when they're in the 47 million. And if I would imagine if we ran our business of healthcare in a different way, we could actually think about this as an exciting point from a clinical perspective because we would not be so overwhelmed thinking about the cost on the population front.
I know we're very early, even to talk about screening or primary prevention, but to even confound the conversations, in April of this year, the CMS made a decision in a memorandum about national coverage determination and approved Medicare to cover monoclonal antibodies as a treatment for Alzheimer's disease when that amyloid is present. So what do we mean when we're looking at monoclonal antibodies? And since the pandemic, we've all become experts, right? Never heard anything about monoclonal antibodies, and now it's just in our regular conversation. But what is meant by that anti-amyloid antibodies for Alzheimer's?
Sure. So I do think the monoclonal antibody space is also pretty popular in your space of oncology. So I know a lot of people have gotten more familiar with that, at least class of drug. In this space, we're talking about medication or an infusion, typically, that obviously leverages your immune system and removes this foreign protein or this excess buildup of this foreign protein, which is the amyloid beta protein, specifically 43. And so that is what the target of this drug is. Now, what's interesting on the coverage determination, and honestly, the whole process leading up till Medicare made its decision, has been this balance of trying to figure out how effective these infusions are in actually doing that and removing amyloid. And so amyloid, of course, has been the primary target. It's not the only target for Alzheimer's disease pharmacotherapeutics by any stretch. There's an entire list on the National Institutes of Health website of the different targets that are being tested, everything from inflammation to, so amyloid's very popular though. And we have lots of failed trials trying to do it. Aducanumab in particular, the one that was ultimately approved by Medicare for use through the accelerated pathway, is very effective at removing amyloid. Then the question was, does that actually improve the Alzheimer's disease? So that's been kind of rough. So you saw lots of issues around their clinical trials in terms of whether it was effective or not in improving cognitive symptoms. Certainly, there was the advisory board or advisory committee to the FDA that advised against approval for lack of effectiveness. And then ultimately, it did receive approval after, I think, being delayed, so we're going to hear about it. Everybody in my world was sort of ready because the moment these things are approved, it's a huge news story. Patients are coming with the printout of the newspaper saying, I'm here for my aducanumab or whatever the drug is, right? They're like, okay, hold on. So we were waiting, and then they would say, okay, we're going to delay it another 3 months. Then we'll delay it another 3 months. And so ultimately made that coverage determination that it would be covered under the accelerated pathway, which is a pathway that you use when the drug or the agent is effective in a proxy measure. So in this case, it is effective in removing amyloid. We just don't know that removing amyloid makes a dramatic difference in someone's cognitive symptoms. And that may not be a fair question to ask of these drugs. So, remember back in our conversation that I said was so foundational, that amyloid rises years, decades before symptoms exist. And so the ideal candidate for these trials are people who have elevated amyloid and no symptom. So then to measure, even over a couple of years, difference in symptom progression or symptom expression in the first place may not be a fair question to ask. And I'm, not an advocate, honestly, in one direction or the other, but just to have a balanced perspective on it, it's a real challenge. The other thing that came out with the coverage determination was initially, the coverage did not require actually saying that someone had amyloid present. And so, the other side of any drug, of course, we talked about the benefit or questionable benefit. In this case, there's a tremendous risk. So up to 42% of participants in the clinical trial for these two clinical trials, Engage and Emerge, had either some brain swelling or bleeding that was detected on imaging because they were imaged every 60 days during the trial. Not all of those were what we would consider clinically significant or symptomatic. And when the drug was stopped, the bleeding and swelling did resolve. And so, but we all think about brain bleeding and swelling, and we're like immediately like, oh no, this is a hugely high risk medication, especially outside of a controlled research environment. And I don't know if you remember, Sandy, but I think about early 2000s when we were talking about the Alzheimer's vaccines, and those were also infusions. And they did also have this rare but very serious issue. And so those were sort of halted, I thought. And then we've had kind of this future generations. But for many of us, I think, anytime you start talking about, brain bleeding in older adults, we're just very hesitant to even go anywhere near that. So absolutely, you only want to give a drug to someone who has some expected benefit, right? Because if you're going to bear the risk, you should also have some benefit on the other side of the equation. So if somebody doesn't have amyloid, giving them an anti-amyloid mAb seems like kind of a crazy thing. So that, I believe, has been adjusted. The other piece, of course, that was ultimately finalized is that it is approved, but only within essentially a phase 4 research environment. So on the one hand, you have more safety, ideally, more monitoring, certainly more resources from people who really know how to use this drug and monitor for the risks of it. On the other hand, you also now restrict it to people who can physically access an academic medical center, honestly. So there's some equity challenges there as well.
In real life, we're not going to do scans every, frequent interval like you would in a study. But what would the patient themselves be presenting with? Is it a headache or visual changes? What would the primary care practitioner see?
Yes, absolutely. So for people who are on this medication and maybe you're just seeing them for their primary care, but you know that they're accessing a specialist for this medication, it is all of those things. It is, in older adults, I always think about atypical presentations though. So I hesitate to say this is the finite, narrow list, but it would be things like headache, changes in their walking or gait, dizziness, certainly vision changes, nausea, anything that looks like increased intracranial pressure for whatever reason. You certainly should have a very low threshold for sending someone for an emergency scan because they may have this bleeding or swelling. I would also say, we spent just a little time, and I don't want to make this about one specific drug because Aduhelm happens to be the first. It is not the last. I expect probably 2 more, if not 3 more, to come onto the market or go through this process as well. I don't expect that we will see the same data submitted to the FDA where you have a negative trial and a neutral trial, and we've gone forward anyway. I don't think any other pharmaceutical company would submit data like that at this point. I don't think it would be accepted. That's just my opinion. And I think you'll see a couple of different route options. So the other thing that's important to know about most of these mAbs is that they're infusions. They have to be delivered in an infusion center, and there are staffing and resource and billing components to that as well. There are probably also like injectable things that may also be an option for people who don't have access to infusion centers. I just want us to know, whatever you think or believe or opine about this particular medication that's approved, I think we probably want to think larger about the class overall and how we want to approach this. Sometimes I wonder a couple of things. I said earlier, is it likely that someone very early in their disease course who gets this infusion and removes all of this amyloid, that they will have either a delay of symptoms or maybe never experience symptoms? I mean, probably, right? That may be. We don't know how many or how effective that will ultimately be. And then the other thing I think to think about or to wonder about is, there are also tau targeted therapies coming. And so, we're going to have to, I think the question of just at least characterizing people with that ATN framework, or at least as available as it is in your area. Do we know what their amyloid status is? Do we know what their tau status is? Most people, we're not short in the US on head scans. We probably know something about neurodegeneration. I feel like people find every excuse to do a head scan, but at least thinking about it foundationally so that you are prepared to know what would be appropriate for them when they're asking you questions about all of these treatments.
Certainly becomes important when you're concerned about family risk and decision for biomarkers. I know that you were at the American Geriatric Society in early part of May, and lots of talk about Alzheimer's disease and impact. And we're coming up on National Awareness Month for Alzheimer's disease in the month of June. Did you learn anything specific when you were sharing at AGS? I mean, anything new?
I think this may not necessarily be new, but I think it is something that we often overlook. Again, back to that original question that you asked about the exciting advances. People only see things in that one space, right? New diagnostics like a blood-based biomarker test, new drugs like mAbs and tau-directed therapies. And we forget that outside of effective drugs that will modify the disease course, we are also offering more robust interventions from a care or a model of care perspective as well, and from caregiver training as well. And so one of the things that we all think about in this world is, okay, when the public hears that there are available drug therapies out there, will they flood our clinics? Will they all of a sudden say, no, I'm first in line for that memory screening, not avoiding it? And maybe, right, if you think about other sensitive stigma-related topics like erectile dysfunction, for example, that can be quite a stigmatizing or a sensitive topic. People were not bringing it to their providers until we had available therapies that the public knew about. So will that happen in the Alzheimer's space? It might. But even in the absence of drugs that change the course of the disease, and even in these drugs that maybe only mildly change the course, not having a drug does not mean we don't have anything. And I think in geriatrics, I hope that we are more comfortable thinking in that way. There are a lot of reasons people still would benefit from identifying what they have and knowing what's causing it. If for no other reason, then we can at least provide some anticipatory guidance about the road ahead and how we will intervene to keep from having crises along this long journey of actually experiencing dementia from any cause. So I just want to remind all of us, we're going to spend a lot of time talking about disease modifying treatments. No one is using the cure word, as they shouldn't. But just because we don't have a cure doesn't mean we don't have robust care, because we certainly do. And there are lots of things that we can provide to both patients and to their support systems of families.
And it's been helpful as people in the news, very famous people now, we're watching their journey with an Alzheimer's diagnosis, and that's been helpful. So I'm going to ask you to take a look in your crystal ball. And what does the future hold for families? Because we know Alzheimer's disease is not just to one person, it impacts complete families. What does the future hold for those that are impacted by AD?
I think the most immediate future is this wider implementation of the CARE Act, which actually includes caregivers as a part of the care team in some very basic and structural ways. So, for example, I work with other practices to implement ways to be more dementia friendly in their general primary care practice. And we are starting to get through this sort of barrier of where's the caregiver's name in the chart? Like, it doesn't exist. And if you think you're going to, implement an intervention plan of any type, new prescription, referral, anything without that caregiver's input, I mean, you are sadly mistaken. And many patients are open to doing that. Then bringing information from a care partner into your information about the patient, since most of our tools for evaluating function and therefore staging are based on someone's observation of them in a day-to-day environment. So I think we will see more immediately more of that, what we call co-production of care at integrated memory care, meaning that, I cannot make these outcomes just happen by writing them on a prescription pad, right? I need to do this in conjunction with the person as much as they're able to participate and with the care partner or their support system. So we bring them in for the information, we identify our goals that we agree on, and then the plan is jointly agreed upon. So I do see some more of that, and we have some legislation to support it. I'm optimistic that we will really start thinking about some of our other financial support of caregivers. We are starting to see a little bit more around people who are not able to work because they're doing full-time caregiving and it's so hands-on, so that they are able to receive some benefits. So you're starting to see some pilot models around that to support them, because caregiving, at least we know, can create burden for individuals. It may strain them. It should not also bankrupt them. And so I do start to see some of that. I think, Alzheimer's disease is still, I think, one of the most feared diagnoses that people anticipate or worry about. I don't know that we have anything today that will change that per se, although I do think it starts to reduce the stigma, to start to normalize that to some degree, that someone is living with a disability. It happens to be a cognitive disability. And then to start to consider how we support them best in places that they would access on a regular basis, like your primary care office or your community of faith, as some of my colleagues are working on. And so I think trying to make space for both that person living with their abilities and their disabilities, and then their care partners.
That's a wonderful, wonderful way to end our conversation, Dr. Clevenger. Thank you so much for sharing your expertise and your enthusiasm for this disease that has such an impact on our geriatric population and their families. And I hope you have a wonderful day. And thank you, everyone, for listening and joining us for GAPNA Chats. I'm Dr. Cassandra Vonnes. Have a wonderful day.
GAPNA Chat is owned and produced by the Gerontological Advanced Practice Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. Dr. Carolyn Clevenger is a gerontological nurse practitioner, professor, and associate dean for clinical and community partnerships at the Nell Hodgson Woodruff School of Nursing at Emory University in Atlanta, Georgia. She is responsible for the Office of Clinical Placement and the Emory Nursing Experience, including the Wound Ostomy Continence Nursing Education Center. She is the clinical director and a practicing nurse practitioner at the Emory Integrated Memory Care Clinic. She completed her postdoctoral fellowship at the Department of Veterans Affairs. Dr. Clevenger is a past president of the Gerontological Advanced Practice Nurses Association and a fellow of the American Association of Nurse Practitioners and the Gerontological Society of America. Dr. Cassandra Vonnes is the Nurses Improving Care for Health System Elders, Niche, Coordinator, Geriatric Oncology at the Moffitt Cancer Center in Tampa, Florida. She is a member of the Gerontological Advanced Practice Nurses Association Communication Team and is a host of the GAPNA Chat podcast series. For archived episodes of GAPNA Chat and to learn more about the Gerontological Advanced Practice Nurses Association, visit gapna.org. You can also subscribe to GAPNA Chat everywhere podcasts are found.